अस्सलाम वालेकुम।
जी वालेकुम सलाम। क्या हाल है, कैसे हैं आप सब लोग?
अस्सलाम वालेकुम सर।
जी वालेकुम सलाम। तो
अस्सलाम वालेकुम। क्या
वालेकुम
हाल है?
सलाम जी, खैरियत। आप ठीक हैं शफीक?
बिल्कुल ठीक ठाक, बिल्कुल ठीक ठाक।
तो व्हाट इज द फॉर्मेट ऑफ दिस प्रोग्राम? क्या पहली टॉक किसकी है, दूसरी किसकी है, और पैनलिस्ट कौन कौन है?
Sir, I'm Dr. West, but I'll be moderating the session today.
अच्छा,
So the first talk तो आपकी है sir on adrenal insufficiency, और then the second talk would be by Dr. Ibrar Ahmed, and then later on we'll be taking the questions from the audience.
तो अब ऐस आपने जो टाइम है फॉर ईच टॉक वो कितना है?
I think we should start now. We were waiting for the participants to time. It's 3
नहीं नहीं,
o'clock now.
ड्यूरेशन पूछ रहे हैं, टॉक कितने मिनट की है?
The session is like 1 hour. I think 20 to 25 minutes
ठीक
per
है,
session. Then we'll give 5 minutes for the question answers for
ठीक
each
ठीक,
session.
चलें ठीक है। दैट मींस के 25 मिनट्स में आई हैव टू फिनिश माय टॉक।
Yes, sir, it would be helpful. If audience के questions होंगे तो then it will be easy.
बिल्कुल सही, ऐसा ही है। तो वैसे आप कहाँ पे सिचुएटेड हैं, कहाँ से हैं आप?
Sir, I'm a consultant endocrinologist at Services Hospital Lahore.
अच्छा अच्छा
Dr. Khadija Irfan, yes.
अच्छा अच्छा, डॉक्टर खुदीजा के ट्रेनी हैं आप?
Yes, sir. Yes, sir.
ट्रेनी थे, यानी कि अब तो आप
Yeah, जी sir. जी,
बन
sir.
गए। अच्छा, गुड।
I'm working with there. Shall we start now?
जी हाँ, I'm ready if your
I
audience
think.
is,
जी.
let me just make sure that I can
Yes, I
share
think
this।
we should start.
एक सेकंड देख लें, मैं स्क्रीन जो शेयर करनी है, एक सेकंड मुझे दे दें आप।
So we'll just give the intro and then we can start it. Mr. Neem will, I think he'll give you the permission to share the screen.
ठीक है, that'd be fine।
जी.
बिल्कुल।
Assalamu alaikum everyone. I am Dr. Awais Mohammed Bhatt. I'm a consultant endocrinologist at the Services Hospital Lahore. And today I'll be moderating this session. And I welcome you all to our webinar on adrenal gland disorders, which will be hopefully a very insightful session aimed at enhancing our understanding and management of these complex conditions. The Pakistan Endocrine Society is celebrating this month as the Adrenal Gland Month. And as a part of this, today's session is first one of the two sessions that have been planned today, and then the second session is on the 26th of April. And in today's session, we will be focusing on two very pivotal topics, adrenal insufficiency and adrenal incidentalomas. And I think these sessions will be extremely beneficial for the endocrine PGRs and the fellows, and we'll be providing them, deep dive into the diagnosis, the treatment, and the management of these conditions, which are very common and sometimes very difficult to manage. So thank you all for joining us, and let's start this together. I'll first of all Professor Khurshid Khan. He's a professor of medicine and endocrinology. He's the head of Department of Medicine and Allied at Fatma Memorial Medical and Dental College, Lahore. He's also a consultant at Doctors Hospital and Medical Center, Lahore. He was also the past president of Pakistan Endocrine Society. Sir, please.
Thank you। Let me just share my screen। Yeah, just give me a second. I'm trying to share the screen. Okay. Can you see my screen right now?
No.
No. Okay, let me just try again।
Host, please kindly give the permission for Professor Khurshid Saab to share the screen.
Because on this link, all I have to do is share screen. And desktop one.
Sir, you have now you can share the screen, please.
Okay, let me just try again. Okay, now can you see the screen or still not? Prof, can you guys see?
Sir, we cannot see your screen.
You cannot. I'm just
Right now we're not able to, sir.
microphone, point, share, access, system preferences.
For all the participants, as we are.
Sir, are you
we-
using a Mac?
Yeah, I'm using Mac.
Yeah, you might need to go to your privacy settings and allow screen sharing to Zoom.
Yeah, that privacy settings. Okay. Didn't realize that.
As we do this, I'd just like to inform all the participants that we'll be taking the questions in the chat session. Kindly share all the questions you have in the chat, and we'll, at the end of the talk, we'll put these questions forward to sir, and then we'll have the answers. Thank you.
Okay. Privacy settings. Yes. Sorry about that. I didn't realize that. Will not be recorded. Yeah, I think we should do it now.
It's working.
Excellent.
Yes, so now we're able to see it.
Okay, great. So, yeah, what primarily I'm going to talk about is adrenal insufficiency and how we can correlate this problem in patients with diabetes and without diabetes also at the same time. I have added a few slides in the latter part of this presentation. Let's start from this case. This is a 38-year-old male back in 1955 with a lifelong history of GI symptoms, which were cramping, diarrhea, inability to gain weight. At age 23, he had episodes of hypotension and syncope. At age 30, his BMI was only 20. He was frail. He looked tired, hollowed eyes, and anemic with bronzed look, and then collapsed on one of his trips to UK. He was U.S. Senator. He was visiting UK at that point as a delegate member from US. And when he was taken to hospital in UK, he was told that he had only 1 year to live. On return to US, he was started on deoxycorticosterone acetate, DOGA. Age 38, he was diagnosed with hypothyroidism and was put on liothyronine. So in family history, this patient had Addison's disease. His sister had Addison's disease. One of his son, he had Graves' disease. So history of autoimmune disease in the family. So when we look at this case, what is the diagnosis? What medications he should be on? And some of you may be knowing who he was, and some of may not. So if you look at his symptoms, let me take you back to the first slide where he started with the GI symptoms, nausea, diarrhea, and inability to gain weight, hypotensive episodes, syncope. and very frail and kind of malnourished, coming off from a very well-off U.S. family, being the senator of the U.S. Congress House. So there was something going on with this person, but it took them until 38 years before they diagnosed this patient, when he really collapsed, that this patient has Addison's disease. He had Addison's disease. He had hypothyroidism, family history of autoimmune thyroid disease as well. So if you look at this complex of autoimmune issues he had, most likely this patient has polyglandular autoimmune syndrome type 2. We'll discuss later on what polyglandular autoimmune syndrome type 2 and type 1s are. And some of you who do not know who this person was, this was John F. Kennedy, JFK, so who was diagnosed at 38 years of age with adrenal insufficiency. And some of you must be wondering why he was put on DOCA, deoxycorticosterone acetate, and not prednisone. Well, of course, prednisone was not available at that point to be used. So this is a lifetime of JFK, which is released very recently in the archives of the Congress, that if you look at early on, he started off even at the age of 17, he's more than 6 feet tall. His weight was only 140 pounds, and then kind of stayed in a like very lean body mass until and here he was diagnosed with adrenal insufficiency at this point at the age of 38. But then look at what happened to him at 43 years of age, because here he was started on this deoxycorticosterone acetate, but which does give you some kind which does give you some of steroid effect. But that's when he was put on steroids, prednisolone, and that's when his weight and his frailty, all those things improve. So this is a course over the course of time, how his BMI, and if you look at the bottom part, continued to have GI symptoms. Adrenal insufficiency was diagnosed around 40 years of age, 38, I believe, and then hypothyroidism later on he was diagnosed with. So what is this adrenal gland? Adrenal gland, as you all know, there's an inner part, that's what we call adrenal medulla, which is 20% weight of the gland, and then the cortex, which is the outer part of adrenal gland, that has 80% of the size of the gland, of the weight of gland. So in cortex, if you look at the cortex, that's divided in 3 parts: zona glomerulosa, which is outermost, fasciculata is the middle part, and radicularis is the inner part. So 15% of cortical weight mass is by glomerulosa, 78% by fasciculata, and 7% by radicularis. What are the different hormones produced by them? Glomerulosa produces aldosterone, fasciculata produces cortisol, and radicularis produces dehydroepiandrosterone, and adrenal medulla produces epinephrine and norepinephrine. So this is the typical hierarchy, how this hormone is produced. From adrenal gland, circadian regulation is there, hypothalamus releases CRH, ACT is stimulated from the pituitary, and that stimulates the adrenal gland, and then cortisol is produced. There are other factors also which kick in as well. Vasopressin also stimulate directly the pituitary and the full pro-inflammatory cytokines. On the other hand, stressors, hypoglycemia, hypotension, surgery, fever, injury, all those stimulate hypothalamus to produce CRH. So this cascade can be initiated. How aldosterone is produced by these by glands, by the cortex. The angiotensin, which is present in the liver, is converted by renin into angiotensin 1. Renin is produced, as you know, from afferent arterioles, and angiotensin 1 is converted into angiotensin 2 by the ACE, which is produced in the lung and plasma. And then angiotensin 2 works on angiotensin 2 receptors within the adrenal cortex and produces this aldosterone there. Functions of glucocorticoids, you all are well aware of this, maintains metabolic homeostasis. That means blood glucose as well as the metabolic milieu of the system maintains. Even the connective tissue, there are impacts on the connective tissue. If you look at the patients with the high levels of cortisol, you will see the loss of collagen, thin skin in these patients. So excessive levels of glucocorticoids inhibit fibroblast as well. So other actions of glucocorticoids, it maintains the cardiovascular function, increases the cardiac output, vascular tone is increased, affects the does have effect on cognition as well, and does impact the immune system through regulating the lymphocytes, and regulates about 25% of the human genome if you look at this. Renin-angiotensin aldosterone system, which already I think I described in the previous slide. Let me skip it for time constraints. Now, coming back to my topic, what are the symptoms of adrenal insufficiency? Remember the case I presented you, those are the typical symptoms. You will see hypotension, dehydration, hyponatremia, hyperkalemia, salt craving, sexual dysfunctions can happen in these patients. Fatigue, GI symptoms are quite common in these patients. Any patient I see unexplained weight loss, I always work them off our cortisol AM levels to see if this patient has adrenal insufficiency as an explanation for his weight loss. People presenting with hypoglycemia, these are the patients where cortisol levels need to be monitored as well. So all those things are important. Hyperpigmentations can happen if the patient has primary adrenal insufficiency and there's excessive levels of ACTH there. Different lab abnormalities, I think I already mentioned those. So the stages in development of adrenal insufficiency. It can be sudden adrenal insufficiency, like we see in cases of adrenal infarction, hemorrhage, tuberculosis, and other infections, or we can see a gradual stepwise pattern of adrenal insufficiency. The stage 1 may be where only the renin rises and aldosterone is normal. Stage 2 is ACTH rises and cortisol is normal at the expense of high ACTH. Stage 3 is there is impaired cortisol response to ACTH, so the cortisol drops down a bit. Stage 4, aldosterone level also drop, and stage 4, 5, both aldosterone and cortisol levels drop in these patients. I'm talking about primary adrenal insufficiency. So the causes, what are the different causes for adrenal insufficiency? Autoimmune adrenalitis is the most common cause in the developed world. Isolated adrenal insufficiency, which could be from 21 hydroxylase antibodies within the circulation. Then it could be part of polyglandular autoimmune syndrome type 1, could be part of autoimmune endocrine syndrome type 2. And then comes the other cause, which is infectious and adrenalitis. If you look at the cause in Western world, we see about 80% of the patients, they have autoimmune adrenalitis. In our part of the world, I still believe there's infections are far more common than autoimmune, and those include tuberculosis, any kind of disseminated fungal infection in the form of histoplasmosis, etc., HIV, syphilis, metastatic disease, that's another factor there which can cause adrenal insufficiency. Adrenal hemorrhage or infarction, especially we have seen some cases of adrenal insufficiency just in recent years from COVID because of infarction, where because of thrombosis and infarctions, we have witnessed some case reports for adrenals there. Then there are drugs which block the pathway for production of steroids, ketoconazole, fluconazole, etc. And then there are other familial conditions which can cause adrenal leukodystrophy, congenital adrenal hypoplasia, and other stuff like this. So to sum it up, autoimmune causes, infective adrenalitis, and then there are other which are there. So now, what is polyglandular autoimmune syndrome type 1? Or the other name sometimes is used for this syndrome is APS, autoimmune polyglandular syndrome. You can say either way. So what the type 1, typically in type 1, which we see hypoparathyroidism, cutaneous chronic mucocutaneous candidiasis, and adrenal insufficiency. and some of these patients can have primary hypogonadism. That's an overwhelming patients. These patients can have malabsorption syndrome. They can have celiac disease as well. Pernicious anemia can be present in these patients. So this is your type 1. In type 2 is typically we see type 1 diabetes in these patients. We see autoimmune thyroid disease in these patients, and we see adrenal insufficiency in these patients, and then few others can be present as part of type 2 polyglandular autoimmune syndrome. So earlier, like I said, in developed world, this is data from developed world, which was published in Lancet. 85% cases of adrenal disease is Addison's disease is because of 21 hydroxylase antibodies there. So autoimmunity plays a major role in parts of the world where infections are not very common. And 60% of the patients who have Addison's disease, they have at least one other autoimmune disorder as well. This is from the cross-sectional study published from the Western European area. Now, what are the different things which can be present there? Thyroid in these patients with autoimmune adrenal insufficiency and autoimmune disorders, about 50% of these patients can have thyroid disorders. Roughly, I would say 10 to 12% have type 1 diabetes. Vitiligo is there in 12%. 10% can have B12, pernicious anemia. 7% have premature ovarian failure. In a standard practice in the Western world is if you see a patient who has premature ovarian failure, you definitely need to screen those patients with 21 hydroxylase antibodies to make sure you are not going to miss a potential case of adrenal insufficiency, which may happen down the line and goes undiagnosed for years. So that's why for anyone with premature ovarian failure, it's worth doing 21 hydroxylase antibodies on these patients to screen for that. Now, the relation of Addison's disease in context of diabetes, we know it can be part of the type 1 diabetes, and type 2 diabetes, well, that could be tricky. Usually it's not part of that, but the treatment, we will come to that, certain treatment models, certain treatment modalities which are used can cause both type 2 diabetes and iatrogenic adrenal insufficiency as well. So in type 1 diabetics, about 10% of adrenal patients can have type 1 diabetes, but the prevalence of adrenal disease in type 1 is only 1.2%. Anytime we see a patient with type 1 diabetes, you all know that we screen those patients for thyroid function test, but all these patients do not need to be tested for adrenal insufficiency, and there are specific criteria. I will come to those criteria in next couple of slides where they should be tested. Other type 1, that which patients with type 1 need to be tested for adrenal insufficiency. Other thing is Addison's disease, when it's in general population, incidence is not very high, but in type 1, like earlier I said, is 10 times more common than general population, the adrenal disease. General population, female preponderance is there. We tend to see in a later stage, but in type 1 Addison's, we tend to see more cases in males, and we tend to see more in younger population than in middle-aged or so. Now, for someone who has type 1 diabetes, we say just screen the patient for thyroid profile, but not all type 1 need to be tested for adrenal insufficiency. So the question is, what kind of type 1 diabetics should be tested for adrenal insufficiency? There are certain indicators which kind of help you decide, yes, this patient is at a high risk for adrenal insufficiency, should be tested for. To save time, let me just skip previous slide and come direct to the indications. So in patients with type 1 diabetes who develop unexplained recurrent hypoglycemia, the development of an associated endocrinopathy, they should be considered for Addison's disease. Cortisol levels should be tested in those type 1 diabetics. And number 2, an unexplained reduction of total insulin requirement of more than 15 to 20% should arouse the suspicion of adrenocortical insufficiency in that patient. Number 3, the development of abnormal pigmentation in a patient with type 1 merits investigation. Anorexia, nausea, vomiting, hypotension are other clues where these type 1 diabetics should be tested for adrenal insufficiency. In children or teenagers with type 1 diabetes, a clue to underlying Addison's disease is a decline in the normal growth, because the cortisol, it does have permissive role on the effect of growth hormone when it comes to height as well. The diagnosis of adrenocortical insufficiency in a patient with type 1 diabetes requires simultaneous investigation of thyroid function and thyroid antibodies as well. Plasma electrolyte abnormalities are not always there in these patients. 20 to 30% of these patients can have hyponatremia or hyperkalemia. When it's present, yes, by all means, those patients should be tested for adrenal insufficiency. Just very interesting data I came across, I thought I will share with you. Mortality in patients with adrenal disease and in patients who have type 1 diabetes and adrenal disease, and the one only with adrenal disease. So in these patients, mortality tends to be 4 times higher in type 1 diabetes and adrenal deficiency when they have combined both problems compared with type 1 only. So this is just a summary of all the data. These patients, for age matched and HbA1c matched, we tend to see higher incidence of retinopathy in patients who have type 1 and adrenal disease and adrenal Addison's disease compared with type 1 diabetes only. So it kind of, the adrenal deficiency, adrenal insufficiency, it increases the risk of these complications in these patients. So every single factor you see in here, retinopathy, neuropathy, hypertension, except for hypertension, maybe is coronary artery disease, stroke, cancer, and infections. These risks are much higher in patients who have this duo of Addison's disease plus type 1 versus type 1 only, for the age matched, for the HbA1c matched, and for the duration of type 1 diabetes matched as well. So how do we diagnose adrenal insufficiency? While checking an 8 a.m. fasting cortisol level can usually make or exclude the diagnosis in a patient, in these patients. So patients who have level less than 5, they have adrenal insufficiency. On the other hand, levels above 12, they're kind of comfortable, but it would be nice to have levels somewhere north of 16 or so in these patients. But again, patients with less than 5, they definitely are adrenal insufficiency, and the ones between 5 to 12 are in the gray zone. Above 12, yeah, depending on particular patient would be fine, but usually it's more comfortable to use a higher number than 12, maybe 16 is better. So there's a split opinion on this upper level. Should only be done in patients with signs and symptoms of adrenal insufficiency or history consistent with that, this testing. And the measurements of ACTH, of course, that can differentiate between the primary and secondary. In primary, we will see higher levels of ACTH. In secondary adrenal insufficiency, there will be low ACTH and low cortisol there. And consistently high ACTH can be a sign of early adrenal insufficiency, because in the last case scenario, the ACTH, cortisol is being produced at the expense of higher levels of ACTH. So someone with ACTH level of less than 5, that's a no-brainer. That's adrenal insufficiency. But when they fall in the gray zone between 5 to 12 or 5 to 14, that's when we really need to do ACTH stimulation test and see what the levels are. So what we want in these patients is after ACTH stimulation, we want their cortisol level to be at least 18 to 20 microgram per deciliter after ACTH stimulation test. So levels like this, they do rule out that. And when we do, and remember, we usually need to do those tests in those patients who are in the gray zone, not the ones with a very low basal cortisol level. Less than 5 is adrenal insufficiency, no need for ACTH stimulation. Any levels above between 5 to 12 or 5 to 14, that's where you need to run ACTH stimulation test. Levels above 14 or so, I think those patients can have, we can watch them, and there's not much needs to be done in those cases. Now, how do we do the glucocorticoid replacement? Most patients usually, I have seen with the adrenal insufficiency, they are overtreated. Earliest manifestations of excessive treatment is easy bruisability, weight gain, central adiposity, and earliest manifestation of inadequate treatment is the joint pain. That's very interesting part. Reasonable to, and fatigue and tiredness, all those things. Reasonable to mimic circadian rhythm with most or all cortisol given first thing in the morning, which should give them we should give them upload them up front, load them with a higher dose in the morning and then relatively lower dose around afternoon. And so we should try to avoid nighttime administration, as it could lead to sleep disturbance as well. Hydrocortisone is an ideal molecule which should be used in these patients, mainly in AM, for dose between 15 to 20 milligram per day in women and slightly higher in men. So 10 to 20 milligram or awakening, and hydrocortisone about 2.5 to 5 milligram in the mid-afternoon is usually good enough replacement dose. And then dose, try to decrease this dose slowly in these patients as tolerated, because if you decrease the dose, blood pressure is good, they are doing fine, there's no dizziness, they are not fatigued, maybe then these patients may need just 15 to 20 milligram instead of 20 to 25 milligram. So the key is lately there's more stress in using the minimal possible dose in these patients. And well, if the patient has primary in adrenal insufficiency, again, there's a distinction. If there's a secondary, usually they don't need much higher dose of glucocorticoid, but primary adrenal insufficiency, we may still need a traditional dose of glucocorticoids in these patients. In patients who have in secondary adrenal insufficiency, again, remember the mineralocorticoid is not dependent on ACTH. 90% of that is produced because of potassium and because of the volume status. They are the major regulators in these patients. So mineralocorticoids in secondary insufficiency are not needed. But in primary, yes, most of them, they do require a low dose of fluorocortisone, 0.05 to 0.5 milligram twice a 0.05 milligram twice a day or so in these patients. These patients should have med-alert bracelets there, and they should preferably have Solocortef vial with them at home in case of emergency or crisis. What is crisis? Usually in adrenal crisis, usually happens in patients with primary adrenal insufficiency plus triggered by stress. Either in it can happen both ways, either newly diagnosed or in established patients where they stop the medication. There's a intercurrent illness there, significant vomiting, GI symptoms, those fever, all in any infection, all those can trigger adrenal crisis in these patients. How do they present? Hypotension, abdominal pain, fever, anorexia, nausea, vomiting, confusion, hyponatremia, hyperkalemia. So if you look at the percentage of these, you can tell the most common ones are hypertension, shock, abdominal pain, vomiting, and hyponatremia and hyperkalemia in these patients. IV line needs to be for management of these adrenal crisis. IV line access is needed. Electrolytes need to be drawn for glucose, cortisol, ACTH, aldosterone, plasma-renin activity. Give them loads of fluids upfront, 3 liters of normal saline in first few hours, depending on the cardiovascular status of the patient. Follow fluid status carefully. 100 milligram IV stat hydrocortisone injection needs to be given, and all supportive measures need to be done. And then we need to continue with IV fluids, and gradually, while they're in hospital, we need to, normally these patients require about 50 milligram of Solocortef IV at least 8 hourly, 150 to 200 milligram of Solocortef during the acute crisis in these patients. And then when they're ready to go home, we can discharge them on a lower dose of steroids there, like previously I said, as the maintenance dose. Just the very last part, I think adrenal cortisol secretion, and in type 2. In type 2 diabetics, we tend to see a higher level of adrenal cortisol secretion. That's based on multiple cytokines within the symptoms. And this is data was published back in 2007 in type 2 diabetic subjects. Hypothalamic pituitary adrenal axis is enhanced, and the degree of cortisol secretion is later the presence and number of diabetes complications there. One last part, I think, yeah, well, like previously I said, the COVID can be linked to both diabetes and adrenal insufficiency there. The mechanism behind diabetes is the binding of SARS coronavirus, which receptor damages islet cells and causes acute diabetes or worsens existing diabetes. And the mechanism behind the adrenal insufficiency in the case reports which have been done with COVID during COVID time is the thrombosis and infarction of the adrenal glands, which has caused adrenal insufficiency in these patients. The one last part which we did not discuss is the iatrogenic. iatrogenic, when you give someone steroids for anything, for psoriasis, for pemphigus, for hypersensitivity of any, for vasculitis, just be careful. You're using steroids, which can be life-saving, they can save lives, but can create a very bad loop where that can suppress their adrenal axis, and those patients may not recover from adrenal axis. So it's good to have some kind of steroid-free period in between, even if those patients need steroid for the long-term management of their condition. So when we talk about adrenal, I think it's important not to forget the iatrogenic cause of adrenal insufficiency. We tend to see patients all the time. They present to me in clinic with a history that they've been taking those injections from some local dispenser or from local doctor for the chronic pains or chronic allergies or chronic rashes there, and they are getting Decadron all the time, and they've been getting for past many years now. They when they stop using it, they are showing all the signs of adrenal insufficiency. Remember, if you keep hypothalamic pituitary adrenal axis suppressed with steroids for a long period of time, these patients may not recover back to normal. So if any patient needs steroids, have to be very cautious, very careful. Just do not create a bad loop there. Use them very judiciously. So with this, I will thank you all for your attentive listening.
Thank you so much, sir, for explaining this vast topic in such limited time. Again, the crux of the presentation, I think it's very important to recognize this adrenal insufficiency, because it's again, in type 1 diabetic patients, as I showed, that the mortality is almost 4 times more than those who don't have the adrenal insufficiency, and the risk of the complications is also increased many folds. So due to the restraints of the time, I think we'll be taking the question answers at the end of the session. And again, most of the questions have been answered by sir in his presentation.
And I'm sorry, Dr. Abbas, I would need a permission from you. I have to run somewhere. Is it okay if I kind of leave now, or you want me to stay?
No, sir. Obviously, we can't hold you back. Thank you so much for your time, sir. Thank you so much. Thank you so much.
Thank you. Thank you.
Thank you so much. So now for the next presentation, the topic is adrenal incidentaloma. Again, it's they say it's one of the things that is most confusing for the endocrine fellows and endocrinologists, whether to intervene or not, whether to take it out or not, whether to treat or not, which one is dangerous for the patient or not. So for this talk, I invite Dr. Ibrar Ahmed. He's a consultant diabetologist and endocrinologist. He's an assistant professor and division head of the Department of Diabetes and Endocrinology and Metabolic Diseases. He was also past president of Pakistan Endocrine Society. So, sir, kindly please.
Thank you, Wes. First of all, screen share. मैं एक screen share हो गई? Is it
yes,
visible?
sir, we can see it.
Yes. Okay. Yeah. Thank you. First of all, thanks to our Board of Management and Dr. Aisha too for giving us opportunity and starting this webinar series for fellows for medicine, fellows and GPs. So have some insights about some common disorders. So the topic which came into my domain is a bit simple, but it is an unusual presentation, and there's so much lacunas in it that we as endocrinologists, we as physicians usually omit that. But with training and with experience, now people are getting in diagnosing the patients with adrenal incidentaloma having functional or some sinister signs. So I will be a bit brief regarding this, how to intervene, how to evaluate, and what are the common causes you should consider when you come across adrenal incidentaloma. So, just as the incidentaloma says, it is that incident. So, this term used in medicine is used as an incidental finding of a tumor or mass during imaging studies such as CT, MR, or ultrasounds that were performed for unrelated reasons. You didn't perform these these investigations, these diagnostic investigations particularly for adrenal pathology, not particular. It is for some other reasons. So in that case, you come across some tumor or mass or something in adrenals. It is known as adrenal incidentaloma. These incidents usually occurs in our daily life. Just in archaeology, the archaeologists uncover artifacts or structures incidentally, and they are digging for some other cause, but they get something like artifacts or structures which help them in other researches. Just as cleaning in our homes, when you got a messy closet, you get something good, which can, the primary focus is for other thing, but you get something which help you a lot, which is usually undiscovered in previous few years. In computer programming, you may come across some unexpected bugs or features which helps in further research, and in cooking also. This is for females. So the incidents already happens that incidentally you find something which is beneficial, which you can look upon it, and which can improve your life further. So whenever you get this thing in mind, that a positive mind find opportunity is in everything, while a negative mind finds faults in everything. Regarding these incidentalomas, they may be unilateral or bilateral. If it is unilateral, the prevalence is usually 1.4 to 7.3% in different studies, which is higher in older patients, about 10%. And the bilateral, it is usually 10 to 15%. And the usual causes are metastatic diseases, CEH, cortical adenomas, hemorrhagic or infections or lymphomas or primary aldosteronism, pheochromocytoma, amyloidosis, infiltrative diseases, and primarily bilateral macronuclear adrenal hyperplasia. These are the usual prevalences, these are usual findings you get when you are looking for a unilateral or a bilateral lesion. Usually one adrenal mass, if present, it may be hypofunction, but other may be hormone secretory. And this, just Dr. Khurshid told you that the adrenal cortical hypofunction, it may occur in bilateral adrenal masses. So either it is non-functional, either it is functional or hypofunctional. Everything is there, and there's a possibility of it. So screening should be done. So what question you have to answer when you come across this incidentoma? The causative factors: is it malignant? Is it functional? Steps of evaluation, management, when to intervene, and follow up. So the causative factors are commonest are non-functioning, subclinical Cushing syndrome, pheochromocytoma, or primary aldosteronitis. Non-functional tend to secrete excess amounts of hormone. So on basis of functionality, the important Cushing syndrome, also known as mild autonomous cortical secretion. It may be without clinical manifestation of Cushing syndromes. and some adrenal incidentaloma secrete cortisol independently of ACTH. Cortical secretion can be under the control of one or more aberrant hormone receptors in patients with unilateral adenomas or incidentally primary microlantular adrenal hyperplasia. So there may be lack of some stigmata which leads to undiagnosis of these subclinical Cushing syndromes, but may present with hypertension, dyslipidemias, diabetes, weight gain, osteoporosis, atrial fibrillation, or evidence of atherosclerosis. So how you will diagnose it? The baseline is serum DHES dihydroepiandrosterone sulfate. If it is low, it reflects ACTH suppression. So serum DHA of less than 40 microgram was 80%, and ACTH secretion less than 10 is 75% specific of subclinical Cushing syndrome. And serum DHA's concentration of more than 100, if combined with ACTH more than 15, in 96% cases, it exclude subclinical Cushing syndrome. So diagnosis is usually on ODSTs, 3 milligram overnight dexamethasone suppression test may be used, because in that case, you may omit the false positive cases. The positive findings may be confirmed with 24-hour unit-free cortisol, serum ACTH, and high-dose dexamethasone. This presents 3% of adrenal incidentoma. The biochemical finding testing is done if you come across a CT finding of unenhanced saturation of more than 10 Housefield unit, but you will not go for testing if it is less than 10. Facts may have abnormal biochemical testing because few need a critical mass before they can become biochemically detectable. So usually you get across large, more than 1.5 centimeter size, which will help you then to come up to do some biochemical tests. So in cases where non-functioning lipid poor or vascular adrenal masses should be are diagnosed, surgical resection can be done. In aldosterone, there are rare and less than 1% causes of adrenal incidentaloma are diagnosed. Majority of patients with are not hypokalemic, but patients with hypertension and adrenal incidentaloma should be evaluated for plasma aldosterone concentration and plasma renin activity. Those persons who are normotensive but were having spontaneous hypokalemia should be tested for primary aldosteronism. Does confirmatory tests are needed before intervention? Yes. If there is evidence of particular condition, you should be looking for it. Is it malignant? The next question arises. Uncommon cause of adrenal incidentaloma. Actual frequency of primary adrenal carcinoma in patients with adrenal incident is approximately 2 to 5%. It depends upon size and imaging characteristics. So size, 90% of incidentomas which are malignant should have a size of more than 4 centimeters. Why size matters? Because 5-year survival in 40% if smaller adrenal adenoma carcinoma is detected. So you have to detect it earlier. Predictor of malignancy besides size are if there is an older age, male sex, non-incidental mode of discovery, high unenhanced CT accentuation. The imaging characteristic in CT, you will based on Housefield units and delayed contrast enhanced accentuation. If it is less than 10, it is usually adenoma. If it is more than 10, it predicts malignancy. The delayed contrast enhanced CT accentuation is another thing. The rapidity of washout, it usually distinguishes between adenomas and carcinomas. The 10 minutes delay after administration of contrast, if there's a washout of more than 50%, it is reported as adenomas. MR convention spin echo MRI, the T1, T2 weighted images, it distinguishes between the adenomas and malignancies, and chemical shift imaging. This is basically based on the elevated amount of intracytoplasmic fats in the tissue or in the mass, which will help in diagnosis adenomas and non-adenomas. The other, if it is non-MR and CT is non-distinguishable, it's not helpful, you can go for PET with either FDG of 18. These scans are usually done in rare centers. This is the typical features. Benign adenoma, it is a rounded, density smooth counter, sharp margination, diameter is less than 4 centimeter, low enhanced CT accentuation, and ISO intensity on MR sequences. While in FEO, there's increased accentuation of more than 20 as compared to non-adenomas, it is less than 10. Increased mass vascularity, high intensity on MRI, CT, and cystic and hemorrhagic changes. Variable size may be bilateral. On adrenal carcinoma, it may be irregular, large size, unilateral location, and high accentuation of CT more than 20 house fields. So if you come across mass and you have to differentiate between benign cortical adrenal mass from less common adrenal carcinoma, so you can take your diagnosis on intervention basis like FNA. It can distinguish between adrenal tumor and metastatic tumor. So if you are going for this adenomas, so which condition you want to exclude before going for FNA? So if anyone had the answer, so you can write in the chat box. Observation regarding management-wise, observation versus intervention or surgical. Surgical intervention is indicated on size, hormonal activity, and suspicious imaging findings. It may be adrenalectomy or laparoscopic. What factors will you consider in the choices of adrenal, open or laparoscopic? So which factor you will consider that you will go for adrenal? The main factor you will depend upon is the size, and cutoff size is 10 cm. If it is less than 10, you go for laparoscopic. You advise your surgeon to go for laparoscopic, or if it is more than 10, open is the preferred choice. The surgical FEO and adrenal cortical carcinoma, adrenectomy is the key. Aldosterone secreting adenomas, again adrenectomy. Adrenal myolipoma, a benign tumor composed of mature fats and interdisposed hematopoietic elements, which can usually followed without surgical excision. But if it is larger than 6 centimeter in diameter, causing large local mass effect symptom, surgical removal should be considered. If it is large, more than 6, myeloma of more than 6, you can go for surgical removal. So which condition will you consider when adrenal myolipoma are bilaterals? So any condition comes into your mind, this is your diagnosis maybe of congenital adrenal hyperplasia. The surgical approaches, as I told you, in subclinical Cushing syndrome, when will you consider for surgery? Age, well-documented glucocorticoid secretions, and lipid-poor adrenal masses. In bilateral adrenal masses, as I told you, that it depends upon functionality rather than size. In primary bilateral macroadrenal hyperplasia, patient can be treated with bilateral adrenalectomy, and patient with subclinical Cushing syndrome may be managing by resecting the large one, not the both of them if it is having subclinical Cushing syndrome. And surgical management should be guided by adrenal venous sampling in patient with primary bilateral macronodular hyperplasia. This is one of the last slide, follow-up of the and surveillance. If you are monitoring your patient with adrenal mass when surgery is not performed. In radiological monitoring, you should be repeating imaging if there is no any other symptoms or sign there 12 months to reconfirm, and consider resecting any tumor that enlarges by more than 1 centimeter during the follow-up period. In biochemical monitoring, autonomous function started and it appears in a form of hypertension, diabetes, or some other features. And if the baseline and overnight DST are done, which is normal, and you can repeat after 4 years. This my last slide, that there's a flow chart showing that if the patient is incidentally discovered having size of 4 centimeter, you should go for the tests like DHAS, 1 milligram overnight dexamethasone suppression test, and if unenhanced CT situation of more than 10 Mayer 24-hour metanephrines for few rule out, and for primary aldosteronism. If these are present, then go for confirmatory test, and if these are present, go for surgery. If these are not present, go for imaging of this structure. Next step is the imaging of this structure. So if this is unenhanced CT SHG of less than 10, then this may be a benign thing. If it is more than 10, you should go for surgery or confirm if you are concerned for malignancy, FNA, and close follow-up of repeated management at 3 months. If it is increasing in size, go for surgery. If this unenhanced CT accentuation is less than 10, then you should repeat imaging at 12 months or repeat diagnostics test at the rate of 4 years. If progression is there in a form of increase in size, growth, or hormonal autonomy, then you should go for surgery. If it is not progressing free of next 4 years, then it is purely non-malignant, non-functional. You should stop your follow-up after that. So this is the uncommon condition I tried in my time that I should explaining when to intervene, what clinical condition comes into mind, and you can get your diagnosis and you can help your patients. So your identity is like your shadow, not always visible and yet always present. Thank you.
Thank you so much, sir. It was not a very simple topic. You were modest. Again, it's quite a confusing thing when we see it in our common practice. And again, I believe the message from your talk would be that it's very important if you find an incidentaloma, we have to make sure whether it's functioning or not. And the second thing, most important, is whether it's malignant or not, because that would greatly affect our management of this condition. So now, if there are any questions, I think we'll be taking those questions now. I think, sir, from your previous question, the answer to the question which condition should be ruled out before the FNA, one of the participants has answered it. It's as a pheochromocytoma should be ruled out before going for an FNA.
It is usually, as always, it is usually few which should be ruled out because of its patient should be not going to hypertensive crisis or this if we are going for FNA in adrenal masses. First
Yes,
question.
again, sir. Sir, another question is how to approach patients after adrenalectomy. I think that was for the Khurshid sir. But again, if you feel like answering to this question, again, the question is how to approach patients after adrenalectomy. For example, in patients who has adrenal mass and if adrenalectomy has been done, so how do we approach that patient?
Usually, in a patient for what condition it has been done, we will follow with the cortisol level, and if because this adrenal patient usually fall with biochemic having hemodynamic, his blood pressure is maintained, his pulse rate is maintained. So we will go for if it is not, we will take the cortisol, send the cortisol, and we will check his cortisol level. If it is done for any other reason, so we have to follow up these patients with under the cover of steroids if the patient is having baseline cortisol is lowish. If it is in the normal range, it depends upon different conditions. So we will be following that thing accordingly. For malignancy, you can go for radiations and chemo. For few, you will be checking his blood pressures, hemodynamics, and in adrenals, you will be again the hemodynamics and the cortisol level in this case.
Right, right. So thank you. Now the last question, I think it's high. How about the high DHEAS levels indicate?
To be treated?
I would think they believe that when doing the biochemical workup, if you suggested if the DHEAS levels are low, it suggests that the ACTH has been suppressed. But what if the DHEAS levels are high? So they're asking which condition does that represent?
So this is the adrenal tumors. This is secretory type, and when they are raised, we will go for the adrenal adrenalectomy. The usual is in some cases 2 times more that is written, or these are then followed accordingly.
Thank you so much, sir, for your time. I think it's we past our time, and I would think we should conclude today's webinar. I would like to express my heartfelt gratitude to our esteemed speakers, Dr. Khurshid Khan Sahab, Dr. Ibrar Ahmed Sahab, for their enlightening presentations and sharing their expertise with us. And thank you to all the participants for the active engagement and thoughtful questions. And I hope that you found these sessions informative and applicable to practice. We should stay connected for more updates on upcoming sessions. And I think we look forward to seeing you again soon. Thank you all and have a great day, friends. Thank you. Allah Hafiz.